Started. Welcome everyone to this session that is specifically looking at the impact that climate change can have on sexual and reproductive health and rights. I'm Emily Peters. I'm a policy officer at the International Center for Reproductive Health at Ghent University. And in that role, I coordinate the ANSER network. And ANSER is an academic network for sexual and reproductive health and rights policies. And that's what I would like to do today is to, as the coordinator of the network, host this session and moderate it today. What we will do today is first I'll give a short introduction to tell you a bit about our network and what we do, and then we'll go to a short video that will introduce our session today. And after that, we will go to our distinguished panel of speakers who will all present a very diverse piece of research that is related to the impact of climate on sexual and reproductive health and rights. And at the end, of course, it's up to you. And we would love to hear your questions. So please already take some notes if you have some questions in the middle of the session. But before to start, it's always nice to know who is in this room. So maybe to start, who of you considers themselves as a health specialist? Can you just raise your hand? Okay, so that's a lot of people. And a climate specialist? I see a few there. I will be looking at you in the questions and answers because we all have a lot of health specialists here, so it would be great to have your input there as well. And then, are there people who are already specifically working on the linkage between climate change and sexual and reproductive health specifically? I see some hands. Okay, great. Let's talk after the session because I think we can do some more collaboration there. And then I'd like to start with the introduction to the ANSER network. So you all know these 17 goals, of course, and this is where our network started when in 2015 the goals were developed. A lot of our researchers, experts in sexual and reproductive health said it will be very likely that a lot of policies will be developed in the coming years around sexual and reproductive health. And we all have the experience that a lot of the policies around sexual and reproductive health are often not based on evidence. And how can we as researchers make sure that these policies that will be developed are much more based on evidence than the ones that we know from before. And that's how Ghent University decided to set up an international academic network on sexual and reproductive health and rights policies. So what we do, our main aim is to build evidence for sexual and reproductive health and rights policies, and we do that through 3 different pillars. First pillar is education. We try to train researchers, master students, PhD students, but also more senior staff, to really train them on the importance of engaging with policy and how to do that. We feel that if we build this capacity of the new generation, that there will be more researchers in the future really engaging with policy and trying to build those evidence-based policies. Secondly, we do a lot of research, of course. That's why researchers are for. And we try to make sure that the research that we do also is translated into documents that is useful for policymakers. We're all often likely to publish in a journal, and that's often the end of a research process. But within our network, we really try to go one step further and to see how we can translate that to policymakers. And then lastly, service to society, where we do a lot of work, often asked by UN organizations or government themselves, where they want to have technical advice on a policy that they're developing, and where we are bringing in the evidence for them to develop the policy. So we have people within our network from different disciplinaries really coming together, and I think that's the strength of our network, is that we have different approaches towards the topic. And we also see sexual and reproductive health as being a very comprehensive thing. This is a bit of an overview of the topics that we work on, but we try to change and adapt those topics as we go. And so one of the topics that came up since last year that we've been working on quite a lot is the intersection between climate change and sexual and reproductive health and rights. We have 42 members, 35 are academic institutions, and 7 are non-profit organizations. We started only as academic institutions, but then we realized that there's a big added value in a lot of capacity within civil society organizations that know better, much better how to translate evidence to policy. And so that's why we opened up our network for non-profit organizations. And for example, Rutgers here in the Netherlands is one of those. A lot of our members are focused in Europe and Africa, but we also have members in Asia, Latin America, the US as well, and one in Australia as well. And we are covering 24 countries. So just to say that this is a wealthy network of experts, and I'm happy to have some of them here today. Before we go into the topic, I'd like to show you a video which is a video that we made as the ANSER network to explain a bit better what that linkage between climate and sexual and reproductive health actually is. There's a lot of people talking about it, but especially when it comes to policymakers, it's not always that clear what it is that we're actually talking about. And so we developed this video. This is the first time that we're showing it, so it's the launch here, so I'm very happy to show it to you, and we'd also be happy to get some comments afterwards. I guess the video will talk for itself, so I will stop here, and then I would like the people in the back to ask them if they can show the video. Thank you.
Our planet is subject to the rhythm of change. We experience extreme fluctuations in temperatures, rising sea levels, and an increase in natural disasters and associated migration. Climate-related disruptions are impacting the essentials of a good life: clean air, clean water, food security, and shelter. This goes beyond any specific group of people, as factors like gender, age, race, economics, education, and social status all intersect to determine vulnerability and resilience in the face of climate change. Join us as we explore the stories of 3 individuals from different parts of the world. Meet Chioma, a Nigerian woman living with HIV, Dimitri, a 15-year-old teenager from Albania, and Nyasha, a pregnant woman living in rural Zimbabwe. A seemingly unlikely connection ties their experiences together: the intersection of climate change and their sexual and reproductive health and rights. How are they connected, and what challenges did they face? You'll discover it all as we dive right in. Welcome to Empowering Change, navigating the intersection of climate and reproductive health and rights.
As global temperatures rise, so does the urgency to address the interconnection between climate change and sexual and reproductive health and rights. And climate change is more than just extreme weather event causing destructions. It goes deep into our personal lives and is a major threat to public health in this 21st century. The interconnection between climate change and sexual and reproductive health and rights encompasses various concerns, including negative impacts to maternal and newborn health, causing complications such as gestational diabetes, low birth weight, and premature births. It amplifies gender-based violence, exacerbating challenges such as intimate partner violence, forced marriages, and female genital mutilations. The displacement and food insecurity caused by the climate change also aggravates human trafficking and sex exploitation. These climate-induced disasters such as floods, cyclones, and drought also strain the healthcare system, disrupting flow of medical supplies and access to healthcare. And this has got adverse impact on health, especially among women, children, and key populations in vulnerable situations.
Let's delve into a story that exemplifies this a bit more. This is Chioma, a 35-year-old woman from Nigeria who was diagnosed with HIV 5 years ago. She was taking medication regularly and her viral load was under control. However, everything changed when the floods hit. Most of the medical facilities were shattered and the supply chains were broken down. Chioma couldn't access her HIV services and treatment anymore. She knows that without her medication, the virus will start multiplying in her body, with the risk of infecting others and her eventually getting sick.
The damages caused by these cyclones and floods to the healthcare facilities and road infrastructure not only disrupt the flow of medical supplies, but also hinders the movement of healthcare personnel and mobile clinics. A study found that since 2011, about 11 million women experience disruption in accessing contraceptives due to displacement resulting from climate change. The disaster risk management policies and programs often fail to address these SRHR challenges. This leads to diminishing attention and lack of funding for sexual and reproductive health services during emergencies. And this neglect also hampers mitigation measures and long-term recovery process. In Bangladesh, for instance, a study among rural women in coastal communities found that there were no sexual and reproductive health services for women in cyclone shelters. Sanitary pads and contraceptives were not included in the disaster relief packages. And there were no healthcare services for women with gynecological and pregnancy complications.
However, disruption of healthcare facilities is not the only climate-related impact on sexual and reproductive health and rights. Dimitri hails from Albania, born into a family of humble farmers. His life took a dramatic turn when he became a climate refugee, compelled to leave his homeland due to prolonged droughts that devastated his farmland and left him without a means of sustenance. Seeking refuge in Germany, he hoped for respite, but instead he found himself trapped in a harsh reality, becoming a victim of gender-based violence. In this foreign land, Dimitri struggled to provide for his family, facing the grim challenges of violence and displacement. The weight of adversity bore down on him heavily, a testament to his resilience against the unrelenting forces of climate change and cruelty in his new, unfamiliar environment.
The impact of natural disasters often goes beyond what we might see on the surface. Natural disasters can exacerbate public health problems that are already highly prevalent as gender-based violence or GBV. GBV can be expressed in physical, psychological, sexual and domestic forms and is committed against persons because of their gender. The perpetrators are mostly people they know. Yet in the case of disaster-related GBV, it is also committed by people whom one has become dependent upon. We then often see forms of forced sexual intercourse in exchange for protection, food, housing, in short for survival. Research has uncovered 3 key factors at the crossroads of extreme weather events and GBV. First of all, when a natural disaster strikes a region, it creates challenges for everyone affected. People might face losses of loved ones, housing, crops, livestock, their jobs and income, which all lead to heightened levels of extreme stress. It has been well evidenced that this increases the risk of GBV. Second, during crises related to natural disasters, traditional notions of gender roles are reinforced, which fuels gender inequalities. Moreover, victims consider the disaster and rebuilding of society as the goal one should go for and not the personal problems one might encounter. In Ethiopia, for example, we noted an increase of 119% of child marriages across regions worst hit by the drought in 2022. At the same time, female genital mutilation increased by 27% as well to make sure that the girls would be considered a good marriageable party. Third, when extreme events strike, known structures of stability and control might fall away. Hence, we see that as law enforcement is not functioning as before, perpetrators have less chance to be stopped or arrested. At the same time, victims have less access to healthcare, while evidence has proven that providing holistic care, meaning medical, psychosocial and forensic care, is essential to recover well from the GBV.
Nyasha is a 30-year-old pregnant woman living in rural Zimbabwe. This summer has been particularly hot and very dry. At 26 weeks gestation, Nyasha noticed some pressure in her lower belly, but thought it was the baby's position. A few days later, she started having cramps and episodes of diarrhea. Nyasha and her partner got very scared, so they went to the healthcare center in the nearest town. A day later, she went into labor. Their tiny baby was born at 27 weeks and weighed just 1.1 kilograms. Which is extremely preterm. Both mother and newborn were hospitalized, and the baby received the extra help he needed to survive. It will be a while before mother and baby can go home, and being inside the hospital is suffocating because of the heat. Nyasha fears for her baby's life and is especially worried about the care plan the baby will need and whether he will be able to grow and develop normally.
Climate change impacts all human lives. It disproportionately affects populations in vulnerable situations, including pregnant women and newborns. Evidence shows the devastating impacts of climate hazards on MNCH. Among this evidence, things like extreme heat that we have particularly researched stands out as an emerging and urgent threat. We know heat exposure is linked to a range of adverse maternal and newborn health outcomes, and these include hypertensive disorders in pregnancy, gestational diabetes, preterm birth, stillbirths, but also after delivery, things like reduced breastfeeding, and also disruption to health service access. Some of these associations are very clear, and we know, as per the WHO UNICEF report, Born Too Soon, which highlights that exposure to extreme heat leads to a 16% increase in the risk of preterm birth. Other health outcomes, such as congenital defects, gestational diabetes, eclampsia, are aspects that are much less well researched, and further work is still needed in that field. Over a third of the world's children, around 820 million children, face exposure to heat waves. Yet information on thermal regulation in newborns and children is still very scarce. We know this population group carries a heavier burden of climate-related health impacts compared to adults, especially due to their physiological and cognitive development. So importantly, heat exposure and heat stress aren't confined solely to countries in Asia and Africa. It's really a global concern. And although low and middle income countries have less adaptive capacity, this is a universal issue that needs collective action across diverse regions.
Drawing from this overview, we propose a series of robust policy recommendations for taking decisive action at the intersection of climate change and sexual and reproductive health and rights. Develop and implement disaster risk management policies that explicitly address sexual and reproductive health services. Invest in climate-resilient SRHR facilities that can serve as lifelines during crises, safeguarding the well-being of communities. Launch robust awareness campaigns to educate communities about the risks posed by climate change to sexual and reproductive health. Promote gender equality policies and programs and empower women and girls economically, socially, and educationally to make them more resilient for climate-related challenges. Develop and implement heat plans, including providing cool shelters, heat-related health information provision, and ensuring access to safe water. Support research initiatives to further examine the direct and indirect impact of climate on SRHR. Provide gender-based violence-sensitive training for healthcare professionals and emergency responders. Develop new or strengthen existing laws and policies related to gender-based violence with a specific focus on addressing issues exacerbated by natural disasters.
Okay, I think this video showed specifically how complex the issue is and how much we are talking about when we talk about the impact of climate on sexual and reproductive health. And that's why we invited today 4 experts who will give a very diverse piece of research and present it to you to make sure that we get a bit of an overview of this all. Let's start with Ijoma Solaren. She's a dedicated researcher at the Climate and Health Directorate within WITS RHI at the University of Witwatersrand in South Africa. Her work revolves around various projects focused on understanding the impacts of heat on maternal and child health, as well as developing strategies to mitigate these effects. One notable initiative involves her collaboration in crafting messages for a heat early warning system designed specifically for pregnant women and new mothers. Holder of an MPH from Emory University Rollins School of Public Health, Ijoma brings a wealth of research and public health experience in spanning 3 continents. Her academic and professional journey has cultivated a deep interest in the intersection of climate change and health, social determinants of health, and health equalities. Her particular focus areas include maternal and child health, sexual and reproductive health, and the health of migrant and minority populations. Ijoma is a fervent advocate for evidence-based policies, viewing them as a catalyst for tangible improvements in community health and the fortification of healthcare systems. Her commitment to producing high-quality research is driven by profound dedication to fostering positive change, particularly across the African continent. Ijoma will present us today some insights on the intersection between climate change and maternal, newborn, and child adolescent health. Ijoma, the floor is yours.
know which microphone is going. Yeah, so that was the first time I was seeing that ANSER clip, and I think originally I thought I was going to do a speed introduction to climate change, maternal, newborn, child, and adolescent health, but they did an even bigger speed introduction. Anyway, for those of you, and I know there are a few people here who have, who've never been introduced to this area, welcome. I'm going to go through a journey with you on that. And for those of you who are immersed in this area, apologize. It is going to be a bit sort of on an introductory level. So this is a general framework of climate change and health, and some of these was already discussed in the ANSER clip that was seen. So of course we've got the direct impacts right on the top. We've got socioeconomic, cultural context, as well as the indirect impacts, which all lead to adverse health outcomes. I only have, I think it's 8 more minutes now. So obviously to go through all this would be a bit difficult. So I'm focusing mostly on high temperatures and heat waves, which is where my research is mostly based. And to demonstrate this, this framework, I'm going to do similar to what they did in the ANSER clip as well. So I'm going to take you on a journey focused using research that has been published, just to kind of demonstrate what this framework is about. So this is a story of Imani, so it's different from the other one. And she's young, she's pregnant, she's vulnerable. She's about 23 years old. She lives in a little rural village. She's a subsistence farmer, so she works the land, and that's what she depends on. And over the last 5 years, there's been increased unpredictable weather in her village. So while weather temperatures used to range from about 24 to maybe 30 degrees, then now they're seeing temperatures and recurrent heat wave events of over sort of 35, 40 degrees. So yeah, extreme heat as well as drought and floods in the area. What does this mean for her? So this is a quote from a different study, but it's quite sad because we have continuously lost our hard-earned produced to erratic climatic conditions. Either the weather will be too much and drown everything, or the sun comes and burns everything. So while these are not Imani's words, they capture her experience at that time. So pregnancy should be a time of great joy, expectation, thinking about, the future. But for her, it's actually quite a precarious situation to be in. The drought and the fact that she works in a farm and losing your produce has meant that there's a risk for both her and her unborn child in terms of the nutritional status. It also means that she's extremely exhausted from working in this farm. She's had to, because there's nobody else to do this work for her, so she's had to do this throughout her pregnancy. What she also finds is that she's had to visit the health facility, which is also an underfunded health facility, for pregnancy complications, including hypertensive disorders, as well as, what's wrong with my slides? Yeah, as well as gestational diabetes. So these are just some of the things that she's had to go through. Nevertheless, Imani does give birth to a beautiful baby girl called Nia. So Nia is born into, Nia was born preterm at 24 weeks. And the doctors also feared that she could have a congenital heart defect. But they persevered through this. And a few weeks later, Nia does leave the hospital. But even with this, they still struggle with the heat, which affects breastfeeding for both mother and child. Of course, this is, a few of the issues that are very fictional in what could happen. But the literature, so our team at WITS are currently working on a maternal health review, looking at the effects of heat on MNCH. And these are some of the studies, or some of the adverse effects that have been linked to heat. There are almost 30 of them. And as you can see, most have a positive, basically there is an effect of heat on them. Most of these studies, I have to say, have been carried out in sort of global north, high-income countries, with very few studies in low in sub-Saharan Africa or low-middle income countries, although that's changing and there's more and more coming out. You can also see that most of the studies, or a lot of the studies, have been on preterm birth, so we've got quite a lot of evidence about preterm birth as well as low birth weight. What this means taken together is that all the gains we've made in terms of decreasing maternal mortality and infant mortality, especially in Africa, could be lost due to the increasingly hot weather. So yes, Nia is born into this world where she's much more likely to experience an extreme heat event, particularly a heat event. You also find that she's malnourished, undernutrition, because of the fact that they're not able to work on their farm anymore due to the drought. Produce is very little. In fact, there's a study, there was a report that also mentions that, I think it's the Lancet report, mentions that with high heat, just even the nutritional value in crops that are grown in high heat is actually decreased compared to like if it wasn't. So not only do you have fewer crops, but you actually also, the plants that you're eating actually have fewer, much less nutritional value. So fast forward on a few more years, and Nia is now an adolescent. And she's thinking about the world where she's come from. So they've had to move from their little rural village where they had a farm, even though it was a harsh condition. They've had to move into an urban environment with other migrants like themselves. They've had to move into more crowded conditions. The school that Nia goes to, the classrooms there are extremely hot. And this quote is from a paper by Kotwayo et al. So pupils in school find it hard to concentrate in the very hot weather, and it's even worse for the female child. One of the biggest effects on adolescent health is the fact the effect of mental health. And Nia, as you can see her here, is kind of looking into the future and thinking about where she's come from, thinking about the loss of her homeland, thinking about what the future holds. And in my head, what Nia is thinking about is about joining Fridays for the Future, thinking about joining an organization that actually fights and advocates to make the world a better place. So mental health obviously doesn't affect the adolescent health process. And I think there's been quite a few talks about this here in the sessions. So these are some of the words that have been coming out in terms of, in the literature, in terms of mental health, called eco-emotions or psychoteric syndromes. And I found some of them quite interesting if anybody wants to have a look on what they mean. So I'm just quickly going to go into what I think are some research needs. I've got like a minute left. So like I said, there's a considerable amount of evidence that we have on the effects of heat. But we have very little evidence from low-middle income countries and sub-Saharan African countries, so we need more of that. And that was also echoed in the recently launched Lancet report that was launched last week. We also need more studies that actually do evaluation of intervention. So while we might know that something might work, okay, drink more water might, reduce heat or different interventions that could work, but we actually don't have a lot of evaluation studies to say this actually has an impact on the actual outcome. Then the third thing I think we need is more understanding of the pathophysiological path of the biological mechanisms that underpin especially the effect of heat on maternal health. So maternal health is quite a complex process, and we can talk about this afterwards, but there's lots of different ways that it could be affected, but we still don't fully understand that. Most of the studies we have that explain it are usually from animal studies. Lastly, I just want to enter into like a few of the projects that we're working on to try and deal with some of these issues. So the first is High Horizons, and my colleague Isabel will speak a little bit more about that. But essentially, we're trying to develop an early warning system for pregnant and postpartum women, which would give them resources and advice when it's hot. And then the HAPPY study, which is heat adaptation for pregnant women and infants, which is a co-produced complex intervention involving various levels from the individual level all the way up. And then the Heat Center, which is a data science project, which is using data from longitudinal data from across sub-Saharan Africa and linking those temporarily and spatially with environmental data to try and quantify the effects of heat on maternal and child health. And with that, I thank you, and I thank my colleagues who are involved in this, as well as ANSER for organizing, and obviously all the study funders. Thanks a lot.
Thank you very much for giving this overview, and also already a lot of tools, I guess, that can be useful for other people in the room here. And then we'll go to Judith Brusselmans. She's our youngest speaker here. Judith pursued her studies in medicine at the Ghent University from 2015 to 2021, followed by the completion of a 2-year advanced master's in global health at various Belgian universities. During her master's program, she gained valuable expertise by interning for 4 months as a health advisor in the office of the Belgian Prime Minister Petra de Sutter. And Judith's master dissertation developed into the profound subject of the impact of climate change and fertility preferences. And that is exactly what Judith will present us today. Judith, the floor is yours. Thank you, Emily, for this introduction. Okay, so like Emily told you, I will be presenting the findings of my master's dissertation, which I completed for my advanced master's in global health. With this picture, I want to illustrate how I came across this research topic. Like poor Newton was confronted by gravity through a falling apple, I was also directly confronted with this research topic in conversations I had with friends and colleagues. Some of them expressing that they didn't want to have kids because they were afraid of climate change. And indeed, climate change is worsening. As Ijeoma just showed you, children born in 2020 have a 2 to 7-fold increase to experience extreme events compared to children born in 1960. So scientists are stating that we are in a crisis situation, and we know that people's wish to have children can change when being in crisis situations, such as war situations. And my friends and colleagues were not alone. There has been quite some attention given to the topic in popular media, as you can see here, and here also. However, I didn't find a lot of papers at first sight in scientific literature, so I decided I wanted to research this topic a bit more thoroughly. I proposed the following research questions for the 2 parts of my research. So first of all, I wanted to give an overview of the research that has been conducted on the impact of climate change on fertility preferences, and I did a scoping review for that. And then secondly, I wanted to get a bit more in-depth insight into this topic, and I chose to do some semi-structured interviews with experts. I will go quickly over this. So I searched in different databases. For the semi-structured interviews, I did purposeful sampling. And then my data analysis, I did in 4 steps. So the first phase was a coding phase in which I did a content analysis of the full text of the included studies. Then I developed an interview guide based on this analysis. Then I did a thematic analysis of the interview transcripts, and I did a triangulation of the results. So at the end of my scoping review, I included 33 studies, and this is a table of the most important characteristics. So in summary, there were over 2/3 of studies that were conducted in Europe and North America. Over half of studies were published in 2021, 2022, and most studies were journal papers. There were more quantitative than qualitative studies and 4 mixed method studies, and most papers came from the sociology, psychology, and demographics fields. After developing the interview guide, I did 9 expert interviews. All of them were researchers with different research backgrounds, and some had relevant experience in NGOs as well. And I identified 3 overarching themes in the thematic analysis, which I will discuss now, together with some findings from the included papers in the review. So the first theme was on changing fertility preferences due to climate change, and I roughly identified 2 different pathways of how this could be. So first, there were studies that focused on directly experienced climate change events and their impact on fertility preferences. Secondly, there were studies that focused on feelings of concern or anxiety, not necessarily induced by directly experienced climate events, but this can also exist because of knowledge of, about the phenomenon of climate change. And experts confirmed these 2 pathways from their experience. No. There is also large spatial and contextual variation in changing fertility preferences, as was shown by studies conducted in different parts of the world. And we shouldn't be blind to these contextual variations. Experts also expressed that they detected that the changing decisions are part of something bigger and more general, which they defined in different wordings. For example, here in this quote, it's illustrating a phenomenon, a broader phenomenon of how human beings are impacted by climate change and environmental degradation, but also how human beings respond to this by questioning their own place on the planet. And then lastly, experts made the remark that fertility preferences are not necessarily reflected in fertility outcomes, for example, because of having no access to contraception or failing contraception. The second theme was on knowledge generation. All experts agreed that there is a growing body of research that only started quite recently. So a lot of them felt they were quite alone in researching or working on this topic. They also expressed different opinions on the value of this research, one of which is articulated here. I think that it adds to the sense of urgency that this really illustrates how some people reason around this topic. There were many recommendations for future research as well, especially longitudinal data was desired, as well as more data from the Global South and adequate representation of different groups. They also expressed challenges in this research field. I will lift out one important one, that's the importance of the historical legacy of population policies from the 1960s and 1970s and the fact that it still influences this field. Even if you're looking towards fertility preferences from a bottom-up approach, a good framing is necessary. And lastly, they all reflected on their own position and background as a researcher on this topic, which was remarkable and encourageable to see. Then the third and last theme was on policy action. It was explicitly mentioned that policy action is not generalizable because of these different contexts, and very diverse suggestions were given: listening to people, mental health support, support for reproductive decision-making, bodily autonomy, climate change mitigation, and rethinking the organization of society when birth rates are falling down. One expert expressed it like this: it's about why, if people have reproductive goals, why aren't they meeting them or why are they shifting them? If it's these external factors that can be addressed in some way, then we should work to address them. So the strength of this study is that it's actually the first scoping review on this topic, trying to summarize existing evidence, and that it has been complemented and contextualized with expert interviews. There are also limitations to this study, so the scope was very broad. It was a global scope, but as fertility preferences are very context and culture dependent, it's impossible to make generalizations how to go further with these results. There's also a limited amount of existing research, which also may have biased the findings, especially as most studies were done in the global north. And furthermore, I did not look in grey literature, which could have been an important source of information as well. Concerning further implications of this research, we need more studies with a well-aligned scope, a longitudinal design. Hopefully this research can be a first step towards this kind of studies. We also need more studies in the Global South and in different contexts and cultures. We need hyper-local research to understand this phenomenon better in these different contexts. Furthermore, we also need to look at the broader environmental picture because climate change does not stand on its own. It's interlinked with biodiversity, environmental health in general, and there are some studies on people's concerns about the near environment, not specifically on climate change, but these concerns, this direct confrontation with environmental degradation often have the same basis as concerns or confrontations with climate change. So in future research, these environmental concerns should be taken into account as well.
And the last point I want to raise is that there are these historical sensitivities that need to be kept in mind, so any policy action taken in the future should be evidence and rights-based. Thank you for listening.
Thank you, Judith. And then we'll go to Isabelle Lange, a distinguished medical anthropologist affiliated with the London School of Hygiene and Tropical Medicine and the Center for Global Health at the Technical University of Munich in Germany. Isabelle's research is a compelling exploration of maternal and humanitarian health, neglected tropical diseases, and the intersection with climate change. Her work is driven by a commitment to bridge the micro aspects of health and daily life with the macro aspects of institutional and policy levels. Isabelle will present today research about the impact of extreme heat on healthcare workers' well-being and performance in maternal and newborn health, thereby also on how climate change factors affect the care of women receiving during pregnancy and labor. Isabelle, the floor is yours.
Thank you. Hello, thank you for coming today. And thank you also to my session co-people who have set this up really well. Because in Idioma's presentation, we heard about how climate change and heat are affecting women, pregnant women, maternal health and reproductive health. I want to really focus in here on the yellow box on the bottom, on how the care they receive and the services that are provided to them are also affected by climate change and excessive heat, focusing on health workers. So what do we know about health workers and about heat at health facilities? We know that there's often suboptimal structural settings that don't allow for good ventilation, that actually trap heat, that don't already have mechanisms to cool. We know that also healthcare workers in many, many settings already face a lot of challenges, have occupational burnout, are dealing with many things and don't need added stress to their situations. There's limited evidence on how heat affects healthcare workers in lower and middle income countries, but there are reviews on occupational health and heat, excessive heat, which shows that there is reduced productivity and increased stress. So in terms of quality of care that health workers then provide for women, we know that they are required to be quick, responsive, to be able to follow guidelines, and yet at the same time, we're also well aware that many women receive substandard care due to a multitude of factors, and also disrespectful care is prevalent. One study in 4 lower and middle income countries in Africa and Asia said that about 30% experience disrespectful care. So this is sort of the lay of the land at the health facilities. And when heat comes into the picture, our idea is that heat impacts personally health workers in terms of thermal comfort, making them more hot, bothered, stress. It affects them cognitively. Their motivation can be lowered, and they can be tired, lethargic. It can be more difficult to do their work. And this, in turn, then has an impact on care provision and on the care that women receive in terms of teamwork, collegial responses to one another, evidence-based practices, and overall efficiency. So in light of this, the High Horizons project, it's a 4-year EU-funded project, aims to look at, identify cost-effective integrated adaptation mitigation interventions to alleviate heat impacts on health workers in Europe and in sub-Saharan Africa. And it's a wide, vast project. Idioma mentioned one aspect of it. I'm just going to be speaking about a sub-study here that is about assessing heat impacts on well-being health and productivity of maternal healthcare workers and the provision of quality of care. So I won't go through all of the objectives, but I wanted just to highlight here that our main points are to look at performance and productivity, well-being, physical health of health workers, and the quality of care they give, all in the end with the goal of co-creating interventions to tackle this phenomenon in the health facilities. So with health workers, with other stakeholders, to develop strategies that could potentially improve situations. We're working in 3 diverse countries with very different climate profiles, really, and in 6 health facilities, hospitals and health centers. So there's also a diversity there. We're doing this field work in 2 stages, one during the hottest time of the year and one during a cooler time so that we can compare and contrast. And our work is focused on maternal healthcare workers, not overall healthcare workers. So we have developed a package of these 5 methods that we think will give us the data that we need, both subjective and objective measures, to respond to our research questions and to be able to develop effective interventions. I'll go through them quickly here. One is time motion. I don't know if you're familiar with it, but it's a quantitative data collection method that involves an external observer, in our case generally a research nurse who's really familiar with clinical procedures, who will capture data on health worker activities, tasks, workflow, and they're time-stamped, and then they're also compared between the hot season and the cooler season. We're focusing on labor and delivery. Here you see a midwife filling out a questionnaire. We have a self-administered questionnaire with a set of validated questions aimed to measure the perceived impact of heat on healthcare workers. A number of physiological measures are being measured. Everything from step counters to see how much health workers walk during their shifts. Is it more, is it less, depending on heat? Core body temperature, the concentration in their urine, skin temperature, heart rate, all these things are also being measured at various points. There's a routine extraction of routine data for a small number of selected indicators specific to maternal and newborn health. And participant observation and interviews, sort of focused ethnography to understand, to be able to observe what adaptations are already being carried out in facilities due to counter heat, and also to talk to health workers. How do they perceive this as a burden? How do they perceive the situation? And it's from these data that I just want to, this method that I want to just present a little bit of preliminary data from one phase of fieldwork during the cooler season in Zimbabwe that we have now. Just to show the type of data that we'll have and that we'll triangulate with the rest in order to try to develop these interventions. One thing is that we're focusing on health facilities, on health workers, but they told us that it's also important what happens outside the health facility. For example, the commute to work can be very hot. Here you have a quote where you see that a midwife already says you want to already start resting before you get to work, so if that's how you start your day. And also, they mentioned that what's happening in their surroundings is really important. Here's one example with a drought, with the lack of rain, which can lead to decreased income amongst the population, weakened immune systems, increased disease, and then more burden at the health facility. So while we're really looking at health workers in this study and what happens at health facilities, it's important to take the bigger picture into consideration. We asked about the perceptions of impact of heat on performance and productivity. We heard about infection control is much more difficult in heat conditions. Again, this tiredness and lethargy. We heard that sometimes they take shortcuts in activities. They admitted like, oh, they don't want to write everything down when they're tired. So this was obviously something that is recognized amongst many of the health workers we spoke to. Physical health, mental health, and energy levels were also mentioned as during the hot season, during hot temperatures, that they were affected. And here you see a quote by a woman who says, "You just feel weak. People from outside will think it's malaria, but it's just the heat." We asked about respectful care of women, and health workers told us that, or some did, that yes, they recognized that they were more stressed, there was more tension from the heat, and that sometimes they took it out on the patients. We can also see that perhaps patients are more stressed coming into the health facility because they also have the commute, they have the heat, they're existing in the same conditions. We did ask them about the adaptations they're already undertaking, and they mentioned some here, carrying water bottles, drinking more, taking a screening of patients outside. We heard that from one person here that they're not very effective, but they're trying. And there was generally a well-received this idea of coming to see what could be done to improve the situation. And that's what will happen here, together with the health workers and using the data that I described before, to go through this method from the situational analysis to understanding where are the points that we can intervene, what can be done, what are the resources there, and hopefully also doing this in a sustainable fashion eventually so that teams can work on this themselves. My time is just about up. I think some of these topics we'll take up in the panel discussion, but one thing I wanted to just mention is really moving from, hopefully the evidence generated here will move from just being project-based to really understanding that this is something that should be considered at a policy level for both health workers' well-being and the patients that they treat. So I just wanted to thank everyone. Thank you for the panel and for coming, and for the team on behalf of whom I'm presenting. And I just wanted to share this photo I received this morning from the sociologist collecting data now, who at 7 a.m. was already drenched just having arrived at the facility to start work. So it's hot. Thank you.
Thank you very much. And then we'll go to our last expert of the day, Anke van der Kwaak. She's a seasoned senior advisor and researcher at KIT. From 2016 to 2023, Anke served as a team coordinator for the SRHR team at KIT. With a wealth of experience spanning 2 decades, she played a pivotal role as a coordinator of health system research module at KIT's Masters of Public Health, and currently oversees the SRHR policy governance and finance modules. Anke has an extensive background in academia, having spent 10 years as a university lecturer at the medical faculty of the Vrije Universiteit in Amsterdam before joining KIT. Her work revolves around diverse themes, including sexuality, comprehensive reproductive and sexual health, climate resilience, and gender-based violence. Anke will present us today the RISE training program for NGO workers working with climate-affected populations. Anke, the floor is yours.
Yeah, thank you for being on this interesting panel. And I'm actually representing quite a team here. You see Ophelia Chatterjee and Tasneem Kakkal are my 2 colleagues who were core in this whole process, what I will describe, but they are both in Ethiopia and India, so they are not there. The RISE program, which was a tailor-made training program to actually strengthen resilience through SRHR information and empowerment, and also link SRHR and climate change, was funded by NUFIC and in that sense, by the Ministry of Foreign Affairs. And it was quite an interesting program because it was only 18 months of funding, and we actually implemented it in the times of Corona, of COVID-19. So there were quite some hiccups. Today, I will present the process of RISE. And actually, when I was preparing this presentation, I was tempted to all the time think, oh yeah, we have to present the training program, There was a research, very interesting research, but also the dissemination. Say, Anke, no research, only the process and the dissemination. So I will talk on the training program. And actually, at KIT, we're doing quite some development of curricula. And we have 3 major SRHR modules, the SRHR theories, the responses, and the policies. But also we apply that in other countries, always in close collaboration with partners. And here we did it with Red Orange, with Mavi, and to the Family Planning Association for Bangladesh and the Institute for Social Development and Education, also in Bangladesh, and with 2 universities. The idea was to actually, through module development, and I will show you later what it meant, to actually inform people working with refugees in climate-fragile situations, but also to do research together to look at outcomes. And you can see curriculum development. We said already, we worked closely with other institutions. We did training of people, of the organizations and the management, but also had cascading training. So people were master trainers and they implemented it. We learned also a lot. I think one of my aims is also to use some of the very important outcomes in our curriculum development at KIT and in other settings. Did I go too fast? No. At the comprehensive sexuality definition as described by the Guttmacher-Lancet Commission is actually leading all our work. And I will not go through it, but it's important to know. And what we did, I think this is the whole trajectory. We did modules 1 and 2. We did module 3. Then we had the cascading training. We did a research trajectory. We also had modules in that. We had evidence, and then we disseminated. So we did that all in 18 months. Of course, because of Corona, we could not teach together there face-to-face, so we did it mainly online. And I think that the focus on both SRHR, climate and refugees, we worked mainly on Rohingyas, but also, for instance, focus in the beginning on people in the north of Bangladesh live on terps, where there is flooding. So there's more on flooding our work than on the drought of the former presentation. And besides that, we also just discuss all sensitive topics, and they did not come from us, but actually what people wanted to know and wanted to learn. What you see, and I think we had a training session 1 and 2, then we had a training session also, and I think that's very important, on how to train others, how to work with each other, how to pitch messages, how to get interest. So we did a lot of that, and we used both mind mapping, but also all kinds of conceptual models. We did case studies, mind mapping, storytelling, people pitching, peer review. So we did that a lot, and then we had the cascading of the training. So the master trainers did it also again with their own people. So the research trajectory was also, and although we ourselves were more interested in a real focus on a more climate topic, adolescent pregnancy came out as the most important. And I'm not allowed here to talk about this very interesting research, what we did and the outcomes, but I think we did it with researchers from the university, the sociology department of the University of Dhaka and Daffodils University. And also the people of the NGOs themselves were integrated in the research. And we went through the whole full circle. And the good thing is that we did also on knowledge translation. And we had, I think, I had the most interesting dissemination events, to be honest. we went to journal settings, public media settings, but we had very interesting gatherings with students from Daffodil and University of Dhaka who really commented on the results, how it impacted on their lives and everything. So we had quite a journey, but very interesting. So these are some of the study aims, and it's on adolescent pregnancy, and I will not go into the details also where we did the studies. We published something like that, handouts, both. Everything was translated in Bangla, and also conceptual models, how it was related, so we also developed them. And we also had, of course, one of the main findings is that climate is multiplying the effects of the refugees and people have. So it's more poverty, more adolescent pregnancy, less access to services, so it's a multiplier effect. Now, this is one of the dissemination at the journal, and we were there in the press, on television, but also with students. So this was a project of 18 months and funded, and of course, what are the lessons learned? The main lesson is that it's very crucial and important to link sexual reproductive health and rights, health systems, gender equity, and climate. And we cannot do that, leave that behind. So we need to integrate that. But there's also, this was a very small project, but there's a need to upscaling and outrolling. So we need fundings and ways to find it to actually make it sustainable. We also saw that, and I have myself an interest in gender-based violence and coercion, that actually climate contributed, the climate change, the flooding, the vulnerability, to more coercion and more gender-based violence. And so there we should really act. So the training in SRHR and teaching was very interesting, but you cannot do it without training management of organization, not only inform students, but also lecturers. There is a need for system change. So we used a lot of digital health in innovative ways. And yeah, so I think the program was small, but very bold, and we got very nice outcomes. So also we got quite some very interesting testimonies on all levels of both the partners we worked with, the universities, with the refugees, etc. So tomorrow I'm going to make also some advertisement after I saw the film of ANSER. We will at KIT have another session on curriculum development in West Africa and also Bangladesh, because this was not the only event we did with people in Bangladesh, but we had at the same time also curriculum development with garment factory workers, with other health workers, with governments. And tomorrow in a session led by Irene de Vries, we will present that also. And we will also discuss more what it means and why we should do this. Thank you.
Thank you. So now it's up to you. You will be able to ask some questions. We have some throwable microphones over there. The idea is that you take it close to the black round part, close to your mouth, and you want to speak. Is there anyone who has a question already? Oh, over there. Maybe good to...
I was very bad in PE at school, as you could tell. Thank God I became a researcher. My question would be for, Rebecca from the University of Munich. My question is for Judith. You looked, I think, more at the sociocultural aspects of infertility and deciding not to have children because of the climate crisis. Do you think there is value, or do you know of research that addresses the biological determinants of infertility that might be tied to climate change. I'm thinking things like sperm count and the like in men, and then other reproductive tract issues for women. Thank you very much.
Thank you for your question. It's not something I did research on because I really wanted to focus on choices and preferences. But I know that there was research on, and I know that some research indeed points towards the direction that heat can also negatively impact sperm counts, and like Ijoma also told, it can also impact maternal health when being pregnant. Well, that can also give more mortality. But I have not done research on it myself. And I wanted to add on that, sometimes people also choose to have more children because of climate change. So it's not only deciding to have less children because you're afraid, but also some families can decide to have more children because there's, for example, more child mortality, and they want the family to continue being so. That's what I wanted to add to it.
Thank you. There was another question in the back.
Hi, my name is Steph. I work for Belgian Development Agency. And thank you very much for this really excellent panel and presentations. As Belgium in 2017, we joined the She Decides movement. And we focused a lot on access to family planning, safe maternity, and so on, adolescent health services, GBV. And so today I'm a bit puzzled. In this conference, there is very little debate and discussion on the access to voluntary family planning as a way of maybe having more demographic control. And so it's puzzling me. I don't know why we are silent about it. I think demographic control is a must. And so I'm puzzled. I'm really lost. I don't know why there is no session in this conference on access to VFP, or maybe I missed it. It's a very dense program. And so I wanted the insights of the expert panel on that. Or
Okay, Anke, you want to respond?
I think also it's not there, and it's very, it's not so nice for you because actually our study on adolescent pregnancy is a lot on that girls really want to have access to family planning and to protect themselves, but it's very hard, and they're prevented by the health workers, by their relatives to actually do that. And I think the whole, you are pointing at the demographic discourse, which is very sensitive at this moment in time. And I think, and now I'm talking as myself at working at Royal Tropical Institute, that it's very hard to talk about even the word population idea is, of course, is very contested. And the idea is often that, and especially when we talk on climate, there it's even more difficult. So I think that maybe people, there are posters on the topic, but I'm not so afraid, I'm not so surprised it's not here. I was just at the Women Deliver conference in Rwanda, and of course there was much more interest for also we contributed to a paper on climate. There's much more interest in climate and family planning, but also what you say, voluntary. What are the needs of people? And we cannot, in the global north, pose something on the global south. And that's why it's so sensitive. Yeah. It's not answering you, I think, but yeah.
Okay. If I may add on that, I think it's correct what you say, that climate change can also hamper access to family planning methods, that some people can't access the right contraception methods, but you say that it's, or you link it directly to demographics, while I think that we should not frame it in demographics control, but more in what in a right to have access to contraception, and we should focus on that individual right and not really on the whole demographic scores, because that's not really the main focus. I think it's really on the right to have access to contraception.
Yeah.
Okay, I think that was a clear response. That you had a response to that? You want to respond to it?
That's the wrong conference, I think.
Okay. Where is the box? Ah, is there. Can we get it? Yeah. I think it's an interesting discussion and important to make sure that everyone has said what they wanted to say. No, back to the gentleman.
I totally agree. It's a very complex and touchy discussion. But I think as a scientific community, we have this responsibility to talk about it. And when I see, and I suppose there is people of WHO in the room, the fact that they left out of the narrative some essential discussions, I think we have this responsibility to continue talking about the access to voluntary family planning as a right, as you say correctly. And with the She Decides movement, we struggled a lot, and we discovered that there is a huge unmet need in a lot of critical populations. So I think it's just a discussion we must have in these rooms. So thank you. And Emilie, don't forget to make some publicity for your conference in 2024, eh?
Yeah. Thank you.
with your ANSER network.
Thank you very much. Is there any other questions? There are some in the back. I see one there as well.
Thank you, and thank you for the wonderful presentations today. What I would like to ask, if we think about equity, inclusion, diversity, there are a number of countries which have been working in high temperatures. Mali, Chad, Niger, Sudan. I don't hear them in the discourse on climate change. I don't hear them in the discourse on the effects of high temperatures. And I'm sure, because they've been living so long with that hot temperatures, they have also made adaptations. So how come they're not included yet in all those research? Well, they're there, they're living it. And can we not look at them for their experiences and their adaptations as best practices?
Okay, maybe that's a question for High Horizons. Isabel?
Yeah, I'm just trying to think. I mean, there is what we've focused on today doesn't include those voices, but some of that is there. I think definitely the learning that has to happen should be from the countries that are really in the extreme heat areas. I know that recently, when I was traveling in, for example, Ghana for another, not for High Horizons, I did hear a lot of like, we just get on with it. We just get on with it. It's hot. It's changing. But I think we need to elevate those voices, the adaptations, the learnings that are occurring there, and bring them into the people who are working on these projects now and policies. I don't know if you
may want to add to that.
I mean, I'm trying to think like how to put this. I mean, in terms of research, it is also impacted on by funding a lot of the time. It's where the money's coming from, it's who's writing the proposals, it's who's getting money. And unfortunately, there are certain countries in sub-Saharan Africa that are funded for specific things, and there are certain topics that are sexier than others, HIV, for example. But So I think there's probably like a lot of different layers involved in why people are not. I don't know about this. I wasn't involved in organizing this. I don't know about who's included in this session or not. And it's such a huge program. There might be other things happening elsewhere. But I'm just talking from a research perspective, knowing that, you know, there are certain countries that might have not adequate resources enough, which unfortunately tend to be a lot of the hotter countries as well that you've mentioned, to be able to actually apply for funding to do research, and maybe not also have the researchers to do the research in those countries. The one thing we are looking at, though, as well is the fact that we're trying to make a lot of the research that we do to be applicable in different scenarios. So as much as, you know, the space we're working in is, so maybe South Africa, Zimbabwe, Kenya, we're also looking at doing those studies in areas that have increased either heat waves or increased high temperatures over the years, and maybe some of that is translatable. Yeah.
Thank you. There was one more question for there.
Hello, thank you for your presentations. I'm Evelie van Kempen, pediatric resident, and I was wondering what your view is on how to implement the sexual reproductive health and rights into the disaster risk management programs. Well, up to my knowledge, we have, for example, the Sendai framework, but these health and rights are, from what I know, not really incorporated into it. What's your vision on that, and how can we achieve it?
Anyone who'd like to respond to this?
Me?
Yeah. Okay.
Yeah, I think there are attempts doing that. And I know, for instance, but I did not get your question fully, or from which position you're asking it. But we tried, for instance, to hand in a proposal which we did not get funded. We are still very sorry. But that was, for instance, with the Red Cross and with the Climate Center, but also with Medicine Without Borders, Doctors Without Borders, and to really integrate at all level SRHR, but also to look at what also the former Priska asked, what is ready in, especially in countries which are also by heat driven, so by countries like Niger, Mali and other countries, and that we did not get funded by an administrative mistake. But I know from that process that there's a real interest, and I think people are aware that should happen. But at the moment, I still think that's also with the academic funding, there's a lot of conscious that we need to go in that direction, but the big funding and the funding also where there are the gaps are not there, is not there yet. So, but I think there's an interest, yeah.
Okay. I thought there was one more. No?
Thank you. I'm Frank Tierney from the Liverpool School of Tropical Medicine. And my question, I don't know if it's tangential, but a couple of years ago, we witnessed the global gag rule that rolled back some of the progress on sexual and reproductive health. And I'm wondering, there is a possibility we may have the same administration in the US over the next few years. And I don't know if you have any thoughts on that, on how these can affect some of the work you're doing, and whether you have any comments.
Can you repeat the question?
What the effect could be of the reinsertion of the global gag rule on your work?
On the
global gag rule.
On our work.
If it would come back, what could be the effect on the work that you've been doing so far?
So in the future, or how it affected us?
In the future, but maybe
if Trump comes back.
Yeah.
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 Oh, I will not think about it, to be honest. We were stopped with a lot of our work, so yeah. So and especially for people who are living in poverty and in climate, they will suffer from it. Yeah. because it will have an effect on on the commodities, on the health service provision, on the rights-based services, and so it will be horrible.
Yeah, I mean, the work that I'm doing right now, hopefully, fingers crossed, is less controversial, I think. So might not necessarily be affected by that. But yes, I mean, I remember working in a sexual reproductive organization years ago, and during the first, I think it was like the Bush gag times, like, well, no, it was, anyway. But yes, and at that point, it was seriously affected. Like, we couldn't get money for anything to start any new projects. But I'm hopeful that with what we're working on now, we're funded through diverse streams, including Wellcome Trust and the NIH. So hopefully, yeah, we don't suffer.
Okay, then I think we got all the questions. Oh, there's one more there.
Yeah, that's not nice. Thank you for your presentations. I was wondering, as some of the topics in sexual reproductive health are also culturally sensitive, I was wondering on how you would think we should have global action points. Like, are these health rights per definition universal, or should we be considerate to cultural differences and have a discussion about that? How do you see that?
Do you get the question? Because there's sometimes difficult to hear the sound.
What to hear?
So it's whether we should, when we talk about sexual and reproductive health and rights, the rights aspect specifically, do we need to think about intercultural differences, or is this one universal idea of rights that we should put forward?
Yeah, but you want first.
I think that's what I, in my final discussion, I reflected a bit on this. And that's why I thought, or I made also the recommendation together with some inputs from the experts to that actually the scope of my research was too broad. So like I was looking globally to give a broad picture, but give recommendations based on this global picture is just not possible, because there are indeed contextual and cultural variations. So I think we need more local research with local collaborations. On the other hand, I think we shouldn't. There is also the concept of cultural relativism, that you are going to the other side and that you say that everything that you don't agree upon is also fine. And I think you can have your own cultural values, and that you just need discussion and open reflection with other people, also with local collaborations.
Yeah, and I think what we do always is never impose something on people. So you do it always in close collaboration, and people set priorities and ask for information. So, because it doesn't work if I would go there and teach and say this and this, so that's not the way how we do it. And I think that also, to my surprise, I was in a program also in Benin and in Mali. There people really wanted to, and that was, for instance, in Mali on medical, there's one medical faculty, and there we integrated SRHR in the curriculum, and people, also the medical students, wanted to be informed. So at the same time, we were teaching even on safe abortion, on sexuality education, on identity. But of course, I'm not teaching that, but our counterparts who are professors, lecturers themselves, or are from local NGOs. And that helps. And I think at the same time, one of the NGOs from the Netherlands was expelled from the country from asking attention for it. So it's also the way how you bring it. And yeah, So I think, yeah, cultural sensitivity is important, but you need to have to lead other people make decisions. And you have always a professional view and a personal view. And I think those you have to work with.
Okay, then we're gonna close the session as we're coming to the end. Just one thing I'd like to ask the speakers, because as ANSER, as I mentioned in the beginning, we always try to look at what is the impact of policy. And I think we heard a lot of good ideas that are out there, new research that's coming, trainings that are set up. We also heard quite a lot of extra research that is needed, some more digging in that is needed. But if you would be in an elevator with a policymaker tomorrow or just here, what would be your main message to policymakers saying this is what needs to be done now?
Shall I start?
You can go.
So first of all, do something about climate change, something serious. And secondly, yeah, listen to people, read about those topics, and don't act before you consulted a population and also its minority groups, because you have to make policy with them also. So yeah.
Okay.
Yeah, we need to know more about how people are coping and how people are coping with climate change and how resilient or not resilient they are. And we do too little studies on that. And I think that's really important, and that should inform our academic studies, but also our policies and programs.
Okay. Ijoma?
Yeah, so we are doing some how people are coping with climate change. Yeah. I think, obviously, there is the big one, as Judith mentioned. You know, we just need to end the whole fossil fuel and have a just transition. Coming from a maternal health perspective in under-resourced or low-resourced countries, we need to look at almost like low-hanging fruit that can be implemented straight away. So we look at low-cost interventions. So things like making sure hospitals are well ventilated, making sure women are properly hydrated during labor. So things like that, things that actually making sure, like, you know, there's enough cooling areas for pregnant women, you know, overhangs, verandas. Low-cost solutions that can be put in place quite quickly is something that we would definitely strongly advocate for.
I think it's to, if it is this elevator scenario with the policymaker, I think it's to really keep the different voices at the forefront of people who are experiencing this, climate change and the effects of climate change, and understanding, I think it's trendy, I think it's easy to sort of get a lot of attention around it now, but really pay attention to who's standing in the way and to try to bring them on board, not just in a greenwashing way, but also to try to continue to make the incentives to work together for a better climate, I guess. So to remember all the voices involved.
Thank you. So I think it's clear a lot is happening. Still a lot will have to be done. Looking forward to the next ASCME meeting to see where we are at that point. I would like to thank all of the speakers of today. Thank you very much for being here, for your interesting presentation. Thank you to the audience for all the interesting questions, and enjoy the meeting. Thank you.